Good afternoon, everyone. I'm Rebecca Vickers with the Florida Alcohol and Drug Abuse Association, and we will get started on time right at 1 p.m. See you all shortly. Good afternoon, everyone. I'm Rebecca Vickers, and on behalf of the Florida Alcohol and Drug Abuse Association, welcome to today's webinar entitled Addressing Stigma of Stimulant Use Disorder in Rural Communities with Deena Murphy. This webinar is being made available through a collaboration of the Florida Department of Children and Families, Office of Substance Abuse and Mental Health, and the Florida Alcohol and Drug Abuse Association. Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, the host, by using the chat panel. The button to open the panel is usually located in the lower right side of your monitor. Please use the chat panel to send any questions you may have as you think of them. The presenter will address questions as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio, there are a few options to try on screen right now, and these options are also posted in the chat panel. If you continue to experience poor audio through your computer, try rejoining the webinar and call in with the I will call in option. You must be connected to the audio of this presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, go to www.fata.org, then to our Resource Center, and then to our training library. FATA produces many webinars and workshops through the support of the Florida Department of Children and Families. To help participants track credits earned through attendance, we host an online community that provides a personalized digital journal where participants can maintain statements of credits for webinars taken through the Florida Alcohol and Drug Abuse Association. At the end of today's webinar, the web browser will direct everyone to an evaluation form on FATA's website. You will also see the evaluation in the chat panel as well. You will first need to sign in or register for an account to complete the evaluation. Information you provide FATA as a part of registering remains confidential. Statements of credit will be posted within 30 business days after the evaluation closes an individual professional development journal for a person completing the evaluation and attending the full webinar. Completing the evaluation is necessary to receive CE credits or to access your statement of credit. Please note that the evaluation will close at midnight on Wednesday, October 27th. Up to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and for persons credentialed through the Florida Certification Board. If you are a licensed healthcare practitioner, be sure to include your Florida license numbers for reporting to CE Broker when you register with our site for the first time. If you are certified with the Florida Certification Board or licensed outside of the state of Florida, you do not need to provide your certification number when you register with our site. Please note, WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. We are not permitted to provide a certificate of attendance if you do not attend the entire webinar, and we are not permitted to provide partial CE credit. Deena Murphy is the founder of Dean Research and directs, manages, and facilitates leadership training, diversity, equity, and inclusion initiatives, research, evaluation, and other types of capacity building support to national and local academic, healthcare, community, and organizational change initiatives. As a community psychologist, Deena has collaborated on community and organizational capacity building related to equity, leadership, and workforce development, substance use prevention, treatment and recovery, the HIV care continuum, team dynamics, strategic planning, and conducted numerous community and organizational assessments and trainings. Deena works with a variety of community-based healthcare and academic organizations from Transform Research to Practical Knowledge, to inform their systems change and capacity building strategies. Deena was the first in her family to go to university, and she received her PhD from North Carolina State University, where she specialized in community psychology and implementation science with a focus on nonprofits and organizational change and learning. As an advanced implementation specialist, Deena consults with UMKC's Collaborative to Advance Health Services to support the work of the Opioid Response Network in partnership with the Network of Technology Transfer Centers. The AIS team specializes in implementation science, capacity building, and system change by working with communities, healthcare organizations, and health departments to build the infrastructure to equitably integrate substance use services and impact opioid and stimulant use disorder. A core focus of Deena's work as an AIS is on addressing social determinants of health, equity, and supporting organizations focused on integrating racial equity and intersectional into the program's policies and procedures. And now I'd like to welcome our presenter, Deena Murphy. I will turn the presentation over to you.
Thank you so much, Rebecca, and to Eric. As all of you know, it takes a lot to put these events on, so very grateful to have the support. And hopefully you'll be hearing more of Rebecca's voice shortly as we ask you all to participate. And I appreciate a couple of people participating in the chat. I asked you to just say hello and let me know what you're grateful for. So we've got people grateful for birthdays. We've got people grateful for their family and the lovely fall weather. And that's what I feel grateful for here in North Carolina. So hello to you all. Thank you for inviting me. My name is Deena Murphy, as you heard from that long spiel, and we're going to talk a little bit today about addressing substance use disorder in rural communities. We do have some kind of required grant slides. I want to make sure you know there's no conflict of interest here. And then these are our SAMHSA grant slides. And SAMHSA, of course, as you know, is the Substance Abuse and Mental Health Services Administration. So we are the Opioid Response Network, and we are a SAMHSA-funded project. And so one of the goals is for us to provide training, technical assistance, resources, capacity building out to the community, to state health departments, to local health departments, to really anyone that's looking to address substance use disorder and specifically respond to the opioid epidemic and stimulant use. So we're very focused, as all of you are, I'm sure, on evidence-based prevention, treatment, recovery, harm reduction around opioid, stimulant use, and substance use disorder. We have local people, so we do actually have a wonderful person in Florida, Karen Garrett, and she is what's called our technology transfer specialist, which is a big mouthful to say that she implements evidence-based practices and she connects people to the resources that we offer, including local consultants, regional consultants, and also national consultants, depending on the topic. So we do encourage you to check out our website, opioidresponsenetwork.org. You can email and also call, and that information will be shared again later. But we wanted to just recognize the Opioid Response Network because they are paying for my time. So again, what are we going to talk about today? We're going to just kind of talk about, the impact of stigma on substance use disorder, prevention, treatment, and recovery, a little bit about those unique characteristics of rural communities in relation to substance use disorder, identify some strategies. What are the strategies that support building partnerships to improve substance use disorder treatment and care? We're really going to emphasize the importance of peer recovery supports and discuss some of those stigma reduction strategies in rural communities. So let's get started. I'm going to share a little bit kind of about our journey today. So why prioritize rural underserved communities? And then we're really, if we were in person, we'd make sure this session is going to be interactive. I see some of you participating in the chat, and I hate that I don't see you and we don't get to hear your voices. So we'll do the best we can with the tools we have. But what we're really going to talk about today is we're going to start with the why. Why prioritize rural underserved communities? Of course, can we ever mention addressing substance use disorder without touching on stigma? And we're going to briefly discuss the impact of the pandemic and some of the existing and new barriers. we'll seek to engage you throughout by asking some reflection questions, and then we'll have Rebecca hopefully support us in narrating your responses in the chat. So hopefully this will make you feel like you have a voice in the process. But if you have questions as you're going, I do have the chat open. I'll do my best to monitor that. I will not respond to technical questions. That would be Rebecca and Eric. And I think there's a reminder again that yes, you will get the slides at the end if you don't have a copy of them now, and this will be recorded. So moving forward, we'll give you a little background as we go into this prioritization. So what you'll see is, as we're going through this, and I hope you can see these graphics, like throughout the presentation, I'm going to share some images from various anti-stigma campaigns. Some of these are statewide, some of them are from organizations. And so the image you see here on the right is from the Massachusetts anti-stigma campaign, and their slogan is, when we stop the stigma, we support recovery. So just a little background, we all know that overdose deaths are increasing, and I know for many of us, you know, the effects of the pandemic have just made it feel like we've taken a big step back. It's really heartbreaking to see the numbers. But some of the pieces I'm sure you're aware of, from 1999 through 2019, the age-adjusted rate of drug overdose deaths increased in both urban and rural counties. So in urban, we went from 6.4 people per 100,000 experiencing overdose death to 22. From rural counties, we went from 4 people to 19.6. And what we saw was a little bit of a shift between rural and urban communities. Rates were higher in urban counties than rural counties in like 1999 to 2003. Very similar through 2004 to 2006. Then we saw a flip for quite some time in rural counties from 2007 to 2015. And now we're seeing much more higher pieces in urban counties than in rural counties from 2016 to 2019. And one other thing we saw is a slower decline in opioid prescribing efforts in rural areas that we'll talk about. You all, I know you've done a good job of some of this in Florida, but we'll talk a little bit about what this means, because some of the differences around overdose deaths, and I really appreciate someone mentioning this in Franklin County, Florida, in the chat, is the key to this is to look at the types of overdose deaths for rural versus urban areas and how those differ. So from 2014 to 2017, overdose deaths, as the slide says, from semi-synthetic opioid overdoses, those drugs we know about, oxycodone, hydrocodone, codeine, were higher in rural than urban counties. And then in 2018 to 19, as we said, it became similar. And then 2019, we're seeing higher rates of overdose deaths from heroin, synthetic opioids, as you know, fentanyl analogs, tramadol, and cocaine in urban counties. So heroin, synthetic opioids, about 1.4 times greater in urban areas than rural, cocaine 2 times greater in urban areas. Now, I'm already seeing a couple of comments in the chat, so I know you're very familiar with where we're going. When we start to look at rural counties, you know, we start to see some of these psychostimulants. Obviously not cocaine as much, but what we're seeing from 2012 to 2019, we see overdose deaths involving psychostimulants. That's methamphetamine and the various types that you see, amphetamines and methylphenidate. We see these are higher in rural counties than in urban counties. So in 2019, the rate in rural counties, which was 6.7 per 100,000, was 1.4 times the rate that we saw in urban counties at 4.8. And one thing we're really paying attention to, and is really sad for a lot of us, is that young adults, 18 to 25, we're seeing double the amounts in rural areas. So we really have to pay attention to this. And the image, I said to you I was going to use images from various campaigns, and I'd be curious to know how you all respond to this, because this got a lot of conversation. This image used by South Dakota, their anti-stigma campaign, and they were very purposeful on this. It received a lot of focus in the media. It got a lot of media press nationally, not just in South Dakota. And one of the primary things it did, which I think made it so powerful, is it got people talking, right? It shows someone that you would think of as a farmer, the neighbor, your grandfather, father, depending on your age, brother. And what it really did was address a huge gap in our perceptions of who does and does not have a substance use disorder. And it's just really normalizing, you know, who can have a substance use disorder? Anyone in the community is at risk. So it was a really interesting and very controversial campaign. And I'm seeing someone saying, you know, using the word meth is powerful in itself in such a public forum. Another comment that it changes the thoughts of the population that are impacted by these substances. Yeah, and I think they were very deliberately controversial. They really wanted to get people talking. So it's quite a powerful campaign there. And talking of the farming community, this is a very interesting part of the conversation. Morning Consult, and this was on behalf of the American Farm Bureau Federation. They conducted this online survey, and it was about 2,200 rural adults, included farmers, farm workers, in 2017. And of course, there's always going to be a small margin, about plus or minus 2% in this. But what you see on the slide challenges our perceptions around substance use disorder again, because what we saw was that about 74% of farm workers reported being directly impacted by substance use disorder. This was either themselves or a very close family member. And yet only 1/3 said it would be easy for them to access treatment, right? So this is a common story. I'm sure many of you that are living in various communities know this. In contrast, 3/4 said it would be easy for someone in their community to access, for example, a large amount of prescription opioids without a prescription. So approximately, 75%, 3/4 saying easy to access drugs. And this is compared to 46% of adults in rural communities overall. So we're differentiating the impact on the farming community. So it really emphasizes to us, again, when we start to break down data, disaggregate data, it really shows us the need to prioritize not just rural areas, but these underserved populations that we don't always think about within these areas. So you're seeing, if you can't see the screen, there's a big sign. I'm sure you're all very familiar with it, saying stay home. We're talking about the impact of the pandemic. And I know that for many of you, you're aware that the pandemic just exacerbated many existing mental health and substance use disorder issues everywhere, but again, really impacted rural areas in some ways, because we saw in a lot of urban areas and increased access through telehealth, and we saw a little bit of a lag for that in some of the rural areas. There's some great opportunities, but not always the equipment available to do that, the bandwidth to do that. So it really created opportunities to increase treatment across telehealth, and it really challenged us to find new ways to engage underserved communities, to address stigma and build partnerships. But as you all know, when we're looking at our numbers, specifically our overdoses, we've got that 2021 CDC predictive data that's coming out showing nationally a 31% increase. States, Kentucky, Louisiana, West Virginia, reporting 60% increases in overdoses, which is heartbreaking for so many of us working in the field. And we're still missing a lot of data, we know that. We're also paying a lot of attention to the changing dynamics of substance use disorder, because when we start to disaggregate data, we're seeing that increases in overdoses in Black communities, especially among Black males, are worse than in white communities. So we're really paying attention to how the pandemic and how substance use disorder is changing, who's accessing treatment and who may be being left out. So this is one of those opportunities, and we'll see how this goes. I'm hoping that you, and just to let you know, when you post in the chat, you won't see it, the rest of the people won't see it, but Rebecca will be your voice. So what examples of barriers to substance use disorder services do you think there are in rural communities? Or you could answer the question, how do you think the pandemic has exacerbated barriers? So we'll let you start to put a couple of things in the chat, just letting us know Okay, looks like people have started, Rebecca.
So it looks like we have people saying lack of services, public transportation, their location, the volume of clients not sufficient enough to produce income, services, costs, lack of a strong system. Mostly transportation seems to be the largest thing.
Yeah, thank you, Rebecca. A lot of transportation, hiding, the cost, technology access, a lot of lack of resources, services, and I appreciate someone mentioning as well sometimes that health literacy, that education, just a lack. I mean, I think lack, and we've also got stigma coming up in there as well. But yeah, really recognizing some of the barriers that are there, lack of jobs. So all these things that we know contribute to substance use disorders. And I really appreciate you all recognizing the lack of technology, because we're all so excited about telehealth and some of the barriers being removed. But whether you have the technology or as someone notices, it might just be that you don't have the signal, the bandwidth in your area. And so you've lost your support system for a lot of people because they couldn't see loved ones or friends. So some great responses there. Thank you all for showing me that you're here. I appreciate your voices. We'll come back and we'll have a couple of others, but if you post things as we're going, I'll try and note them as well. So as we've discussed, rural counties, right, they've seen significant increases in overdose deaths. This image, the one you're seeing here, is from the Indiana anti-stigma campaign, showing their slogan, "Stigma never helps." And all the things you put there in the chat, I think you got everything I got down here: transportation, a lack of those evidence-based treatment options, gaps in services, some of the social norms as well. I'm not sure if all of those were mentioned. And stigma, just creating barriers to substance use treatment for rural residents. Stigma is often cited as a reason why something like, for example, office-based opioid treatment, OBOT, is limited in rural communities. So we know, for example, approximately 30% of rural Americans live in counties without any access to buprenorphine, without a buprenorphine provider. And this is compared to about 2% of people living in urban America. So we know our approach is often urban-centric, because there's more people, right? There's more people, closer proximity to impact. And a lot of the times we're funded on how many people we serve. So it makes sense that that's what's happening. We need greater resources. I'm seeing some of this in the chat. Things really shut down a lot. We need greater resources, more funding, more opportunities for engaging people in rural areas in treatment. And so let's come to a second reflection. I think you're all getting this chat down now, which is great. So what do you think, if I was asking you, what's the biggest barrier to substance use prevention treatment and recovery services in rural communities? If I was to ask you that, and you've already highlighted, yeah, we've already got money, funding, a lot of availability of providers. So a lot of people talking about funding, transportation again. Oh, a good comment here about people coming in from the outside. So recognizing that, it's about building trust. A lot of people saying getting funding, transportation. You seeing anything else, Rebecca?
Most of it is just lack of funding and transportation, the availability. Some people say telehealth is being taken away, so that's going to impact them, but it's mostly transportation.
Great. And all of the, and people are like, I agree with everyone. Yeah, there's so many different ways in which we're seeing these barriers. And one of the barriers that I think, or I feel underlies many of these, and I'm not saying by any reason this is the main barrier, but some of these trust issues that we're here seeing in culture really revolve around stigma. So there's many reasons and barriers. Stigma is a huge barrier, and I know that's everywhere, but we're going to talk a little bit about why exactly in rural areas. So stigma, it's stigma, it's stigma, it's stigma. Everywhere I go, we talk about this. And this is the Alabama Department of Health with the slogan, "Stop judging, start healing." They're doing a lot of great work in Alabama. And stigma and negative perceptions of substance use disorder people in substance use disorder treatment and recovery, medications such as medications for opioid use disorder or mental health medications, just collectively undermine prevention, treatment, recovery responses, and are really correlated with ongoing substance use. We see this in reduced retention and engagement in treatment, access to treatment, non-fatal overdose rates, and really just suboptimal or poor healthcare delivery. And this, as you've mentioned, with really some of the questions, some of the pieces in the chat, this is exacerbated in rural areas, which lack those transportation options. We know drive times, for example, to opioid treatment programs are longer than to a federally qualified health center and significantly different to urban areas. So it really reinforces that need to expand treatment in rural areas while addressing stigma to increase that access to treatment and care. We know that interventions to address community-based stigma around substance use disorder include mass media communication. I'm showing you some of the campaigns that have been up, educational campaigns, law enforcement training, and school-based interventions. So interventions to address provider stigma around opioid and substance use disorder include curriculum interventions, as you know, at different levels, at schools, undergraduate, graduate, continuing medical education, as well as mentoring. A lot of mentoring needs to take place with primary and other healthcare providers where we connect them to addiction medical specialists. And one of the most important that I love that I'm seeing a lot of comments about this is that we need more peers. We need more peer support services. We need more people with lived experience getting out into the community, telling their stories, and just that use of storytelling, right? Where people with lived experience of substance use disorder share their experiences in a way that promotes positive messaging around recovery. It reduces stigma. It improves the attitudes of community members, medical providers, toward people with substance use disorders. And I'm getting an amen peer support. Yes, we are so blessed to have amazing people willing to give back to the community. And the increased use of peer recovery support services, and we're going to talk about this later on in medical settings, is really correlated with increased engagement and retention in treatment, as well as addressing and reducing provider stereotypes and stigma. So just talking through, and we'll come to this a little bit, about interventions. We know some of these things that work, and providing some insights into addressing stigma in rural and underserved communities, and just reinforcing the need to engage diverse community stakeholders with addiction professionals and people with lived experience in long-term recovery, trained to share their stories and promote positive messaging around treatment and recovery. While also sharing that science, right? That evidence-based approach to prevention, to treatment, and to recovery to help people understand the disease of substance use disorder. So just in case you are not as familiar with stigma, and here we have, oh, this is from Down Home, North Carolina, no more stigma, no more shame, talking about overdose could save a life. So what is stigma? We can break it down a little bit to these three types there. Of course, stigma is stigma. We've got this idea of public or community stigma. And this is really those attitudes and feelings expressed by many in the community toward people living with mental health or substance use disorder challenges, or their family members. So I'm sure many of you, you're on social media, you've seen memes, you've seen signs that really kind of suggest there's a moral failure. You've seen comments in the print and the media. However much we try and redress this, we still see a lot of these comments. We see images of people overdosed in their cars. You know, we're not seeing a disassociation there. We need, you know, which is one of the reasons why it's so important to have peers and people in long-term recovery. So we've got a lot of that stigma that exists. And then that goes into institutions. Like institutional stigma is when those negative attitudes and behaviors around mental illness or substance use disorder, which can include social, emotional, behavioral programs, start to be incorporated into policies or practices or culture, social systems. So education, healthcare, employment, it's all integrated. So usually the bias targets specific, easily stereotyped and generalizable attributes like race, gender, nationality, sexual orientation, age. And even though we know direct discrimination is illegal, many believe that that indirect discrimination is very pervasive in social institutions and daily social practices. And then one of the most painful parts is that we internalize that stigma, right? That self-stigma. And this occurs when we really take in that messaging, those disrespectful images that a society, a community, or a peer group perpetuate. And what this does is it can lead people to refrain from seeking treatment for their mental health or substance use disorder conditions, and just lacking trust in institutions. It can cause a lot of lack of hope, self-esteem and confidence, and just creates this horrible cycle, this vicious circle of coping by using substances to combat the pain of stigma, leading to more stigma, self-harm, substance use disorder more intensely, or just an exacerbation of mental health problems. And then we also have, I want to just touch on another aspect of this which might not be clear, and that's about how does stigma affect family members. And we call this sometimes courtesy stigma. And it means sometimes family members and those associated with people with mental illness or substance use disorder experience avoidance by others because of stigma. One of the ways we see this is in faith-based communities, for example. Like, what is the first thing that happens if someone has a life-threatening disease, a chronic disease, cancer? Everyone's showing up, right, with baked goods. How can I help? Can I support the children? But that doesn't happen with substance use disorder. We don't see that. We see that people are unsure how to interact. And that's all about stigma. There's a challenge that, you know, mental health and addiction services receive less funding because of the type of service they provide. And so communities lose the positive resources that people in long-term recovery could provide. And it just perpetuates, the stigma perpetuates fears about mental illness and addiction. So how does stigma impact individuals? And we'll touch on this a little bit, but really we want to reinforce that internalized stigma, which happens when you cognitively or emotionally absorb these stigmatizing assumptions and these stereotypes, and you come to believe them and apply them to yourself. And this really limits a lot of things. And what we've got written here is it can limit your ability to get or keep employment, to get or keep housing, to get healthcare, to find that acceptance and support with your family and friends, or even to make new friends and enjoy long-term relationships, all an important part of recovery, as we know, and take part in social activities. And then how does stigma impact individuals? Continued here. Prejudice and discrimination become internalized, as we said. When we internalize these, we have so much guilt and shame. And when you're not feeling good, you know, it is so much harder to stay in recovery when you're feeling that shame, you're feeling that guilt. It doesn't allow you to make good choices, or it doesn't enable you to make choices that are healthy for you because you're really not liking yourself. Same thing of keeping things a secret. People avoid getting the help they need. And then mental health and substance use disorder issues are less likely to decrease or end. I'm hearing a couple of comments, or seeing a couple of comments in the chat about you know, how it can interact with intimate partner violence and violence in the home, isolation. So really, if you haven't got the message, I think it's pretty clear. We're really saying stigma complicates this disease of substance use disorder, and it really impacts recovery. And if you can't read that slide, there's a little graphic. There's a person with a brown paper bag on their head, which says stigma in big letters. And it's saying stigma can reduce your willingness to seek professional help, cause reluctance to attend treatment, limit access to healthcare, housing, and employment, diminish self-esteem, exacerbate depression, and affect your personal relationships at the time they are needed most. So stigma, you know, not only inhibits help seeking, it might attenuate the impact of help when it's eventually accessed. So some of the examples, and I know, and if you have examples, you can share them in the chat, and we'll talk about this again in a little bit, but people with substance use disorder and those on agonist therapy may not be accepted to treatment facilities, to recovery housing. So there's that question, right? We still have some of that stigma around, well, if someone's on medications, are they really in recovery? We know these are life-saving medications. They are approved, the science is all there. But what are we projecting in our language, our actions? Are we supportive of all pathways to recovery? Opioid agonists like methadone, buprenorphine, or Suboxone, you may know it as, really work to prevent withdrawal and reduce cravings, and it will really help stabilize people. We know this works, but what we see sometimes is people on agonist therapy might not be offered organ transplants. They might be mandated to treatment as a condition of probation, and have a positive toxicology report and get imprisoned. So there's some complications. We also saw there was a study done by Johns Hopkins about stigma, and it said only 22% of people surveyed were willing to work with someone suffering from substance use disorder, but 62% were willing to work with someone suffering from mental illness. So we know substance use disorder is just one of the most stigmatized conditions in the US, around the world, in fact. People don't want to work with, be related to, or even see people with substance use disorder in public. And we know that many people, as we've said, and I'm seeing a couple of things in the chat, people with substance use disorder can or can be denied housing, employment, social services, even healthcare. We see that clinicians often have lower expectations for health outcomes for patients with substance use disorder. So this in turn can affect whether the provider believes the patient is deserving, in quotation marks, of treatment. And some healthcare providers still believe that substance use disorder is within a person's control. They don't see substance use disorder as a disease, and they cite feelings of frustration and resentment when treating patients with substance use disorder. So, and I appreciate the comments in the chat as well, saying, we still see colleagues who don't see Suboxone as helpful, but rather as using. No, exactly. And we know these are life-saving. This is treatment just the same as with everything, every other medication we take for any other disease, any other chronic disease, diabetes, hypertension. So I'm asking you, and we're already getting some examples, how does stigma show up in your community, and what impact does it have? And it looks like we've already got some good comments in there, Rebecca.
Yes, it does. So it looks like we have some programs that won't take on people that are in MAT. It looks like some people, might be a learned behavior or a habit. So those are some of the answers so far that we've gotten.
Yeah, it sounds as well like, sorry, go ahead, Rebecca.
Oh, that's okay. As some people say, maybe it's the community not being supportive of people who are being treated with MAT. Some people say it's insurance that might cause an issue.
Yeah, we're seeing the criminalization, and that's a huge issue. We don't see a standardization across this with substance use disorder. So depending on the county, things can be treated criminally. Yeah, there's fears as well of how it will affect the family. The community isn't in agreement. Programs are just not equipped to help people with substance use disorder, especially people with co-occurring disorders as well. Oh, and I love this. Someone mentioned the importance of trauma-responsive care, and that is often not implemented or understood. We're having people being told that, when they're having medications they need, that they're taking too much, they need to titrate off, they need to detox, and we know that that is not something that we support medically. There's a lot of concern about how programs are being interacted, misunderstandings, and just some limited resources across that ASAM spectrum of care. Oh, and I really appreciate someone mentioning pregnant and postpartum women. Yeah, there is a lot of challenges for pregnant women with substance use disorder, and we know that there are that they can very safely take buprenorphine into their pregnancy. And in fact, it's a very healthy way, rather than going through withdrawal. And yet there's still some confusion, and we see a lot of homeless people being treated as third-class citizens, left to die, especially when we know that 80 to 90% of homeless people have mental health challenges. And then small communities creating barriers of fear at times, where people don't want to be seen at a provider because everyone knows you. Oh, we're going to talk about that. And then we've got a couple of comments like, it's about harm reduction. Yes, so really we don't see as much harm reduction being as implemented as we would like to. So keep posting things and we'll come to them, but I'm going to move on because we want to talk a little bit about, what about Florida, right? So when we're talking about rural Florida, and I don't know if you can see this, I'm going to list the counties in a second, but I just want to define rural is really that idea of there being a population density of less than 100 individuals per square mile, or maybe an area that's defined by the US Census as rural. There's a lot of different ways to define rurality, but in general, it seems like the rural counties in Florida are listed here. I'm not going to go through them. I saw a couple of people earlier mention a couple of these counties, or I've seen a couple of these counties mentioned in the chat. I saw Union, Franklin, Highlands as well, and I think one of the others. So this is just a list of the rural counties, and we're going into a little data, but I don't want you to close off now. I'm going to tell you the story of data. I do love me some data, and I love data because data tells us a story. And one of the things I love about data is when we have data, we have visibility. When we have visibility, we have priority, and we can bring and direct resources. So this is why I always like to break down and have a look at some of this data. So you're looking at some data here from the Florida Department of Transportation, the Office of Policy Planning. And these next two slides, I'm going to show you some examples of rural counties with high levels of poverty. And poverty is measured, if you don't know, in the United States, it compares a person or a family's income to a set poverty threshold, or a minimum amount of income that's needed to cover basic needs. So people whose income falls under the threshold are considered poor. So in 2016, which is the most recent data for most recent year for a lot of this data across the US, the national poverty rate was 12.7%. So there are about 40.6 million people living in poverty. Florida in general has a lower level than this, as you can see, at 11.7. But let's compare that Florida average to the rural average. So in the bottom, it's in yellow if you can't see it. The bottom row is the Florida average, and the first column is for people, the percentage of people across Florida that graduate high school, which is at about 89%, who have a bachelor's degree, about 28%, medium income of about 49,000, and percentage living in poverty of about 11.7% or 12%. So what we're looking at above that, and we're going to see this on the next two slides, are some of these rural counties. And we're comparing, we can compare in general that Florida average on the bottom line to the one above it, and that's showing you collectively the rural average. So when we look at all those counties together, what do we see? Like what are you looking at when you're looking at educational attainment, household income? What is it that you're seeing? I mean, look at the difference. It's staggering in some of those numbers. Florida's rural counties have lower educational attainment than the rest of the state. So think about that for health literacy, as someone mentioned earlier. On average, 55.5% of the population in rural counties, which is nearly 1 out of 2 if you think about that, have attained a high school diploma, and 9.3% have attained a 4-year college degree, compared to that statewide average of 89%. So you've got about 56% graduating high school as opposed to 89%. You've got about 9% of people with bachelors as opposed to 28% across the state. And then we see in that household income that rural counties have a median household income that is $10,000 less than the statewide median household income. So this is really important things, and we'll come to this. But we see here that many of Florida's rural residents are also considered transportation disadvantaged. And I know I saw a lot of comments about transportation. So we've got a very savvy group here, because you know that if you have transportation disadvantage, it means your people, including children who, because of a physical, a mental disability, your income status, or inability to drive due to your age or the disability, are unable to transport themselves or to purchase transportation and have no other form of transportation available. So these people are dependent upon others to obtain access to healthcare, employment, education, shopping, or medically necessary or life-sustaining activities. So I hope you can see, you know, we're talking about the Florida average of 11.7% of people living in poverty. And we see in some of these counties, Hamilton, 26%, Gadsden, 24%, and we'll go down, and we've got some more on the next slide, but just really, you know, more than double in a lot of these counties of the people that are living in poverty. So again, you see Putnam and Holmes and Madison at 25% as compared to that Florida average. So what I want to ask you, and we will talk about this a little bit, is what do you think? How do educational levels, income, percentage of people living in poverty, how do they correlate with substance use disorder? What do you think? How do these things that we just talked about and showed you? Looks like things are coming in, Rebecca.
All right, it looks like we have one person that said farm workers and rural farmer in Florida are a transient workforce, but may be included in these stats and are not normally from the area and may not have access to services. Limited income equals increased stress levels. Maybe they turn to drugs to escape. You have some people that say poverty obviously can lead to mental health problems like depression and anxiety. It's potentially low income. Some people that are lower income are higher risk due to certain conditions. Low income can lead to high stress. So a lot of lower income, it appears, could contribute to this. Lower education equals lower income.
Yeah, I see a great comment in there as well about someone saying they found a direct relationship between poverty and the number of emergency department visits for overdose in specific zip codes. So really important, and people recognizing the power of health literacy. The higher the education contributes to really understanding some of the dangers around substances, maybe some harm reduction strategies, and really saying how education, you know, correlates with jobs, money, housing. So some really great comments in here. One other thing I don't think I saw in there was one of the things we know about long-term unemployment and shortage of mental health conditions is that it's associated with higher rates of neonatal abstinence syndrome as well. So that's one area I know that we're all looking at constantly. Oh, and some very good comments about intergenerational substance use. Yes. How children are exposed and introduced to use early. It is normed in their family or in the community, and that can kind of go into that, you know, that intergenerational circle, which is very important to break. And that's one of the reasons, I don't know if you heard in my introduction, I always re-emphasize I'm the first person in my family to go to college, because as you know, if you are the first person in your family to go to college, you know that's life-changing for your lineage. It is a game changer whenever we can break out of these cycles of poverty and lower education and employment. So thank you for all these responses. I really appreciate this. And I know whoever the person was that mentioned this earlier is going to be happy to see this word up there. I think they were very concerned I was not going to talk through the social determinants of health, but here we are, one of my favorite topics of discussion, because I think this is just helps us understand so many things. And if you have not seen this expression before, and again, this graphic's very small, you will have the slide deck to look at, but social determinants of health are the complex, integrated, and overlapping social structures, policies, economic systems, which include the social and physical environments, health services structure, and societal factors that are responsible for most health inequities. So examples, if you'd like something concrete, I'm a very concrete person. I'm like, well, what is this really, Deena? Okay, well, it's gender inequality, it's structural racism, it's stigma, it's poverty, it's citizenship status, it's education, it's housing, transportation, as we've mentioned, health systems and services, our social safety network, food insecurity, unemployment, or your employment and your living conditions and working conditions, public safety, and whether you feel included or excluded in your society. And what is really important about social determinants of health is that piece where it says they're integrated, they're intersecting, they're overlapping, because these social determinants of health intersect to either promote the health and well-being of communities or to prevent individuals and communities from reaching health equity. And these social determinants of health create differential impacts around substance use disorder, the opioid epidemic, stimulant use, and the current COVID-19 pandemic, as we're all seeing. So if we were in person, one of my favorite things, because we have such a lot of great contributions in the chat, you all have the knowledge in this room, is I would ask you all to tell me in the chat to kind of build on, we create a big pyramid of things. How do social determinants of health show up in substance use disorder? So if I were to ask you to outline how social determinants of health show up in substance use disorder, and I was asked you about barriers to prevention, what might you say? And I'll wait a second to see if something comes up in the chat, and I'm going to refer you to this wonderful graphic. This is from the Rural Health Information Hub, and they have a social determinants of health in rural communities toolkit. We're doing some great work around really how to engage and address some of the unique characteristics of rural communities, making sure things are, available, accessible, affordable, acceptable, and culturally responsive. So barriers to prevention, we've got some comments about the criminalization. Yeah, the fears around criminalization, available resources, finances. Anything else, Rebecca? Things are slowly trickling in.
Police involvement was mentioned, of course, more funding.
Yeah, so as far as prevention, what about so one thing that was mentioned earlier? Oh, yeah, some nice comments about if there aren't things to do, you're going to find things to do, and those things, those recreational activities may not be the recreational activities that we would choose for a community. So we already talked about this, and I really want to reiterate that there can be a lack of protective factors in the family, right, in the community, which we talked about earlier, could be based on the community norms, the family norms around substance use, access to those substances. We talked about criminalization. There's also that impact in communities of the disproportionately high rates of incarceration in families of color, which is really impacting that whole family dynamic and generations. Lack of employment opportunities. I saw a lack of access to primary care. Someone saying, everyone knows everyone's business, and so you're really in rural areas. So a lack of trust in the system or privacy. And what about that high stress environment? I don't know if any of you grew up in poverty, but if you grew up in a family that was lower socioeconomic, you probably know what that feels like a little bit, about that high stress environment of living in poverty, where your priorities lie. And then what if you're a single mother with young children working 3 jobs? Suddenly that use of stimulants to stay awake makes a lot more sense as a coping mechanism. I am not advocating, I'm just saying that we see this and that can impact that prevention. What about, and we're also seeing that cultural piece, someone recognizing one of the counties is rural. A lot of the industry is based on tourism, which is intimately connected to partying, to alcohol and substance use. So it can cause a lot of high stress. And then we see a lot of these people, prevention issues. People have got fears about what's going to happen to their children. And very nice that someone mentioned adverse childhood experiences, which I'm sure you're all very familiar with. But the higher the adverse childhood experience scores, the stronger the correlation with whether someone will struggle with substance use disorder, have income issues, mental health issues, etc. So what about care engagement and treatment? You know, we've mentioned some of these, but it could include a lack of access to evidence-based care and treatment, as many of you have mentioned. Perhaps, you know, it could be due to availability, could also be due to transport, as you mentioned. A lack of medications available or treatment available for opioid and substance use disorder. We know that there's a lack of prescribers in rural communities, but just a general lack of treatment or people able to provide treatment. Ongoing fear and mistrust of the medical experience. We saw that highlighted before. Could be previous experiences of prejudice, could also be related to that stigma. And then we talked about, if you're living in poverty, there's a psychology of poverty, right? That's something we know about a lot. So my priorities, if I'm living in poverty, are going to be on survival. I need housing, I need food, I need safety for my family, rather than seeking care, adhering to a medical treatment plan. And I saw a couple of people mention as well about people who are uninsured or underinsured, just might not be able to cover the cost of ongoing treatment. So all this flows over again with recovery barriers as well. With recovery barriers where it includes a lack of recovery supports and key wraparound services needed. Transportation, again, figures across prevention, treatment, recovery, transportation to any recovery services. There's a lack of recovery housing, especially for those on medications. No safe spaces. People are saying, you know, a lot of times people are in survival mode. It's hard to focus on recovery. Maybe there's no safe space or home. The family or community environment, that county that someone was mentioning before, being supported by tourism that promotes partying. So that family, that community environment is really not supportive of recovery. Big waiting lists as well for various service centers, a lack of integrated care, that one-stop shop that we need for those chronic health conditions and to address co-occurring. So really, really appreciate all the great contributions that you all are making. Oh, and some good mentions as well of the importance of lack of services and supports for teenagers, adolescents. We know that's a huge group that we're looking at, and yet what do we see? So I'm going to do one more slide, and then I promise you we'll take a 5-minute break. But all this is just to say there are clearly linkages between poor health and structural factors such as poverty, lack of opportunity, and substandard living and working conditions. Counties we know with the lowest levels of social capital have the highest overdose rates, and economic hardship, social isolation, hopelessness are all key reasons for drug use. So we know that poverty and substance use, as it says on the slide, reinforced by these untreated mental health disorders, a lack of stable housing, are really cited and correlated as main contributors to substance use disorder in poorer communities, underserved communities. We also know what works. So I want to end with that before we take this 5-minute break to say, we know that viable employment, safe housing, and community reinvestment initiatives are needed to reduce these high overdose deaths. So I believe, Rebecca, we're about close to the top of the hour to take that 5-minute break you wanted.
Yes, that is correct. We will go ahead and take our 5-minute break now, and we will meet back right at 2:04. See you all soon. Hi, everyone, and welcome back to today's webinar. Deena, I'm going to go ahead and pass it back over to you.
Thank you so much, Rebecca, and I hope you all enjoyed that long break that we had. But I appreciate that you all made a priority for us taking a little time, because I know that if you are like me, you sit on a lot of these webinars, so it's always nice when someone thinks about the biological needs that we have and gives us an opportunity to stretch. So again, I'm a big data person, and as I said, what I like about data is it tells us a story, and it's a story that we often need to pay attention to. So one of the things that I like to pay attention to is the impact of social determinants of health. Now, we're missing data on a number of rural counties, so I pulled 4 for comparison across various indicators. And what you'll see highlighted in red are what I'm highlighting as kind of the worst number we want to see in that category. And this data comes from, there's the University of Wisconsin have something called county health rankings data. And I could maybe post that in the chat. But it's really an interesting model that they have there. They do a lot of good work. So let me put that in there. Okay. And this really reinforces the importance of disaggregating data. So hold your breath, because I'm going to walk you through some of this. I know that there's some acronyms in here, so I'll walk you through it. And one of the things I want to be really, really crystal clear about, I am not saying these counties are the worst. I am saying there are some structural challenges around social determinants of health which are impacting some of the numbers we're seeing. So I don't mean in any way to critique these counties. I don't know what's happening. It's just important that we look at some of these numbers so we can do something about it and prioritize it. So the first measure you're seeing is life expectancy, the average number of years a person can expect to live in Florida. And I pulled this in 2021. It uses data from 2017 to 2019. So it's saying in Florida, the average life expectancy is 80 years old. Well, look at how that changes in some of the rural counties. Union County, it's saying, is 12 years younger. So the average number of years a person can expect to live in Union County is 68 versus the 80 that you see on average in Florida. A little bit of difference in others, but it's just things to pay attention to. Premature mortality, same way of looking at this, premature age-adjusted mortality. And this is the number of deaths among residents under age 75 per 100,000 of the population. And again, same data usage from 2017 to 2019. So we see in Florida, that's 340, on average in Florida, 340 people per 100,000 of the population. Union County, 920, higher in every county, in fact, every rural county, but we're seeing that number. Same with HIV. PrEV is HIV prevalence, the number of people aged 13 years and older living with a diagnosis of HIV infection per 100,000 population. And this is using data from 2018. So 607 per 100,000 across Florida. Look at that in Union, almost 4 times the number, 2,226. Close to double in Jefferson County. So just paying attention to some of these numbers. Overdose deaths, again, these are the number of drug poisoning deaths per 100,000 population. And I'm using the data from the county health rankings for this. So you'll see a little bit of change as we go through some other slides. But again, looking at that increase number in Union County, we look at vehicle deaths on average, 14 per 100,000 across Florida. We see above average in the other rural counties, 29 in Okeechobee. And please correct me if I say that wrong, but we're seeing double the number in Okeechobee County. PCP is the rate of population to primary care providers. And this is from 2020 data. So that's saying in Florida in general, there are 1,380 people per primary care provider. And then look how that number changes in Union, in Jefferson, and Okeechobee. We see in Jefferson, we're at 4,760 people to 1 primary care provider. We look at this for mental health. We see the ratio of people to mental health providers. In general, across Florida, 590 people to 1 mental health provider. And now you're looking again at counties like Jefferson, and you're seeing 2,850 to 1 for mental health providers. So really a significant difference between what we're seeing. And then the PCP other is saying, other than physicians as a primary care provider, because we know we've got a lot of nurse practitioners, we've got a lot of PAs. So we're saying other than physicians, is that where what we're seeing? And it's like, well, no, in Florida in general, for other people, 830 people to 1 primary care provider who is not a physician, versus we see a significant difference still in rural areas. Same with some of those suicide rates. This is the number of deaths due to suicide. And I saw someone mention this earlier. And we see the increases in suicides in counties like Monroe, which I know someone posted about earlier. And then at the bottom, I want to explain why I have this. And this is, as I said to you earlier, we're very closely watching the dynamics of substance use disorder, who's accessing treatment, who's not, how racism interacts with that. And so we always want to disaggregate and look at the data and look at what's the percentage look like of people in the county who are Black or African American and Latinx. And so we're really looking there. Florida is pretty diverse, as you know, and as someone mentioned earlier, not everyone is counted in this data. And so just really paying attention to keep a lens on that and maybe breaking down that data, which I don't have access to. And so going down the next slide, we're looking at health disparities. And one of the things in rural Florida, and I want to pay attention, if there are differences in the numbers here, it's just because we're coming from a different data source. So this data source is the Economic Research Service, ERS, it's their 2019 data. And so one of the things that we're talking about is that many rural residents live farther than 30 minutes from a hospital. So what does that mean? It means if you need treatment in an emergency situation, there's a lack. It means that there's a lack of access, as we saw, to primary care providers and other health professionals, such as behavioral health providers. We know that there's a lack of internet access, as you all talked about. Low education rates mean low health literacy, which, as we've seen, affects patients' ability to understand, to have access to health information, and just those low levels of social capital that we talked about in many rural counties, a lack of resources, high poverty, and poor health. And we saw that poverty rate in rural Florida being substantially higher than in urban areas. So paying attention to that. There's a couple of questions in the chat as well. I just want to let you know, I'll come back to some of those in a second. Let's just get through some of these pieces. So when we look, this is coming from Florida Department of Health. This is that dashboard you have. It's great. I love looking at that dashboard and the different ways you can pass things up by county. Again, there's missing data on a number of rural counties, which is a big part of the problem we'll talk about. So I pulled 4 for comparison across different indicators. And again, we're always looking, what's the story? What story can we tell from this data? It's a little bit of projection, of course, so we need to do more digging. But I want you to look at that Florida average for all overdoses and then compare that to rural counties. And every single example from these rural counties, Highlands, Jefferson, Monroe, and Taylor, and this doesn't mean all rural counties, it's just these 4 I'm pulling, have a higher average. But then look at opioids. Look how that story changes. And these are the things to pay attention to. You know, some of this is related to the great work that many of you have been doing in Florida around prescribing, right? When we look over at those prescribing rates, we see the prescription data from 2020 is those 2 last columns. And the third column is the per patient prescriptions. And then the last one is the per provider prescriptions. And we really see, again, some substantial differences, changes happening, some great things happening, and even more, there's some later data on that. And we're seeing that Florida has really shifted as well and doing better. And we're seeing Florida data changes. So that number that says 143 there, meaning the per provider prescriptions, in 2020, that was reported as 116. So a significant improvement. Same with patient. We're seeing 4 versus that 4.2. And then we're seeing that shift again in 2021. That number drops down to 93.3 and 3.3. So what it's saying is you're making an impact around opioid prescribing. Even when I looked at Taylor, for example, it improved for 2021. Highlands improved, so we're seeing shifts, but that gap that we're seeing is around stimulant overdoses and not engaging people in treatment. So we have to pay attention to what the numbers are telling us about where the epidemics are shifting to. So I'm seeing some comments as well about, sometimes the funding is earmarked for opioid use disorder, but the issue in our county might be alcohol, it might be stimulants. So really thinking through about ways that we can address and advocate for that. We are funded, so even though we're called the Opioid Response Network, I just want to be clear, we are funded for stimulants. That was something we all fought really hard for because we were hearing in rural counties, in tribal communities, in a lot of different communities of color, stimulants was the issue, and it was really creating a barrier to us getting into those communities. So we really advocated for that, and I know that that's been a big change across all SAMHSA funding to really include and focus in on stimulants. So again, looking at non-fatal overdoses, we know that rural counties collectively have a higher average, and that's when you put all the rural counties together and look at their average versus the state average. You see they have a higher average. And this piece here, Hope, Healing, and a Fair Chance, that's from the Kentucky Comeback Campaign, another statewide campaign. As was mentioned earlier, there's always a potential for missing rural data. We all know that if you're in a rural county, you've usually got limited staff, resources, less ability to record fatal, non-fatal overdoses. At times, we also see that well-intentioned medical examiners, medical providers might not report the death as an overdose, similar to what we saw with HIV, because they think somehow, due to the stigma, they're protecting the family. So we know for a number of reasons, numbers could be underrepresented of the true number of cases occurring in counties. And we saw this right with COVID-19. This is a picture of an article that you all had in the Sun Sentinel saying deaths were not recorded as COVID if the patient was not tested beforehand. So in rural counties, they were saying the severity of the pandemic's impact could be understated. So we've got one more reflection. And that's just to get a little bit about you. So what do you think as we're coming in to talk about, why is stigma around substance use disorder and behavioral health a major barrier in some of these rural areas? And some of this you've already spoken to, but I want to just hear a little bit again, if you've already said some of this. Religion. Okay, that's a good comment, because we know that religion can be a protective factor, but if substance use disorder and substance use is heavily stigmatized in the church, then it becomes, as we talked about earlier, well, if you have cancer, I'm showing up with a casserole, but if you have substance use disorder, I might not show up. Getting a diagnosis can be seen as a label, old belief systems. What else are you seeing, Rebecca?
I'm seeing small communities, lack of information about substance use disorders, potentially labels, not trusting people, afraid of what others will think. Simply getting diagnosed can be seen as a label for some people, and that can be hard to deal with.
Yeah, there's some great comments rolling in, people talking about, when you're in a small town, you might not want people to know because, they know your car, that perception in the community might be that addiction is about willpower. They might not know that they know someone in recovery. There's a lack of resources. Shame is coming up a lot. Shame's a big one, because shame and stigma, they just sit hand in hand. And I love that some people say not knowing recovery is possible. And that's why it's so important to have our peers out there, or people with lived experience that can speak to that power in recovery, and really give a face to the disease. Good sexual orientation. There's just a lot of different things in a smaller community when people know you, not wanting to lose your job, I'm seeing. not understanding that return to use is a part of recovery. That's a great comment. A lot of time people don't realize that's just part of the healing process. People thinking that they might have clients who know their children, or it can be embarrassing, a lack of information, just low self-esteem, not realizing you can recover, and a lack of prevention programs for youth. Just a lot of people. Oh, you've got some great comments, and this is great, Rebecca. They're very engaged. I love this group.
Yes, they are.
So thank you for all of that. And I'm going to talk a little bit, again, all the things that you really brought up is there's less resources and services available. Of course, it's a smaller area. And lack of treatment facilities, as we know, means people have got to travel greater distances, often to neighboring counties, in order to receive services. Someone mentioned this earlier about self-reliance. I can't remember how it was worded, but just that part of, there's a stigma in asking for help, right? You don't ask for help, you take care of it. It's a part of the culture in some rural communities. And especially when there are many rural areas still criminalize substance use. Some of that has not caught up. Some of the things that are happening in urban areas around decriminalization, around the engagement of law enforcement, may not have happened in all of the rural counties, or there could be a very powerful sheriff in one of those counties that has a very big influence. Some of you are mentioning again, fear, there's that diminished privacy, that difficulty maintaining confidentiality. Everybody knows each other. The local healthcare provider might serve on the school board with you. You might be friends, as someone mentioned, with the clinical staff. And who knows your vehicle? Everyone knows your vehicle, which means that they know when you're at the clinic. So there's a lot of anxiety and shame, which goes into that shame people noted around being seen in or at that treatment facility. And this is that goldfish bowl effect, which just magnifies the stigma around mental health and substance use disorder. The smaller the community, the greater the stigma. And stigma kills. We want to be very clear about stigma kills, because people will do whatever they can to avoid being stigmatized. And this includes waiting to seek treatment until the very last moment when conditions worsen, or maybe not even seeking treatment at all until it's too late and we experience those overdoses. So I don't want to leave you with the impression that there's a negativity about rural culture, because rural culture can be a very protective barrier as well. I want to be clear about that. It is important to reinforce that rural culture can serve as a protective barrier in some ways that you all noted, as far as, maybe religion and spirituality, which can be protective when there is that engagement with a faith-based community, when they're addressing stigma, when they're building a recovery community within their faith-based community, and it can be a very therapeutic effect. We know that often family units are closer in smaller towns, so there can be a stronger supportive structure, really important relationships, which if people are isolated in urban areas might not be there. And that sense of community, which is really important, is stronger in rural areas. People will support their neighbors when they understand substance use disorder as a disease, when they really know people in recovery and they really diminish that stigma. They will support their neighbors in times of need. And someone pointed out that for them to get help for themselves or their children, just knowing they work in the mental health field is a protective factor. Yeah, so it could be that you already know people. It's easier to connect to people that work in mental health and substance use disorder. So we shouldn't make assumptions. And if you know one rural community, you know one rural community. Each community is different. There are similarities, but we need to recognize the distinctiveness of each community. So we've got to ask the questions. Someone mentioned before about fear of outsiders. That's because we often, and I'm not saying you do this, but I'm saying sometimes we don't listen or hear the community values, what's important to the people there. So really thinking through how can we make those better connections and not make assumptions, because rural communities are diverse. They may or may not be religious and want that to be part of the therapeutic approach. So we really need to listen to those individual and those community needs. So this is just a quote. The sources are there from a paper by Mike Knudsen, just saying it's time to decrease health disparities, improve health equity, and advance public health, because the bottom line is this: what's good for rural residents is good for all of us. And health disparities in rural communities have to be addressed if we are going to advance public health. So strategies to address stigma, coming back to you, what are some strategies that you know of? I already saw a lot of great comments around peer storytelling. What are some strategies you know to address stigma in rural communities? Great, we're seeing education coming up there. Yeah, education, the science of addiction, understanding person-centered language, wonderful. Person-first language, language matters. A lot of people highlighting education. What else? What are some strategies you know about? Oh, policy change. That's a good one, Rebecca. We always want to see that.
Yes, and speaking out about your own recovery, and a lot more peer support. ACEs forum for awareness, town hall meetings, possibly with an open discussion. Sharing your own experience, 12-step fellowship.
Yeah, and I love this comment as well about connect with leaders in BIPOC, that's Black, Indigenous, and people of color communities who can speak in culturally sensitive ways. Yeah, when we're including communities, we ought to include everyone in the community and prioritize those most impacted by overdoses. Seeing a lot about community support, public promotions, community awareness, those success stories. We need to reinforce recovery is possible. This is what it looks like. It looks like me. It looks like you. And then we can really reach that, what I see there, acceptance without judgment. We just need to talk about it, as someone says. It just makes it not so shameful. Really great comments, all of you. So some of the examples, and we'll go a little deeper into pieces here, but rural strategies, you know, one of the gold standards, as you know, is a one-stop shop for all your healthcare needs. So we've got this model, I'm sure you're all aware of it, from the Substance Abuse and Mental Health Services Administration and the SAMHSA and the Health Resources and Services Administration, HRSA. They've got this standard framework for levels of integrated care. And so this is just kind of a way to shift from isolated or siloed care to really integrating care between behavioral health and primary care practitioners. So you've got that coordinated care, right, where it's just like minimal collaboration, maybe collaboration at a distance, communicating about shared patients, but really having separate facilities. But it can be a way to help patients make appointments before they leave, provide warm handoffs. Then you've got co-located care, which is more collaboration on site, more systems integration, where in one rural community, a primary care practice might be located in the same facility as the mental health agency. And so the primary care provider can walk the patients over to the agency and introduce them. Again, a warmer way to make a handoff. And then, of course, that gold standard of integrated care, close collaboration across providers, joint plans, goals, co-managing patients, maintaining shared schedules and integrating things. So you've got a systematic clinical approach to identify patients who are in need of behavioral health services and engage both providers and patients in that shared decision-making. Of course, training and education, you all put the power of those in the community, and this includes law enforcement, being clear about that, EMS, and healthcare workers. This is very critical. This is supported by laws and programs such as Good Samaritan drug overdose laws and expanding rural naloxone programs. So Good Samaritan drug overdose laws, and you have one of those, and I can drop some of that information in the chat in case you are all not as familiar with it, so I can drop some of the language in there. But these Good Samaritan programs provide immunity from arrest. They provide immunity from charges, prosecution for drug possession or paraphernalia when individuals who are experiencing or witnessing an overdose summon emergency services. So Good Samaritan laws do vary across states. I just put the information in for Florida. Some states also provide expansive protection from violations of probation, parole, restraining orders, other protections from arrest. And what are the things that we learn about Good Samaritan drug overdose laws? Well, they reduce overdose deaths. First and foremost, most importantly, people live. And available evidence shows that that fear of arrest is really a common barrier to calling 911 during an overdose. The fear of police involvement, which has come up a lot in the chat, can lead bystanders to delay or forgo calling 911. And that just increases the risk of overdose, Beth. So we know how powerful this is. I'm seeing people in the chat saying this needs to be advertised more. Yes, it does. That could be part of a really solid communication as well, in a variety of counters, just to make sure people know that these exist, especially our younger people. And so we talked about the rural naloxone programs, and these programs, I've got some examples here. I'm in North Carolina, as I mentioned to you, and so there's a couple of programs of excellence here, Project Lazarus, and rural programs, that implement naloxone distribution programs frequently cite the importance of contracts, memoranda of understanding with partnering agencies like pharmacists, primary care providers, law enforcement, hospitals, other key community stakeholders. They just really say it's partnerships, it's partnerships. They reference the importance of community buy-in and participation in the development of these programs. And by involving the community in the beginning stages, reaching out to different underserved populations, rural programs report being better able to address the attitudes, perceptions, and stigma associated with working on issues related to opioid use disorders. So I'm seeing a comment in the chat about we have a number of undocumented individuals in rural communities that are reluctant to involve anyone due to fear of deportation. Yeah, so just really clarifying, what will and what will not happen, and making sure people know if you call in because there's an overdose, this is what will happen, this is what will not happen, and getting that message in as many languages as is needed. Someone asked me to go back to the previous slide, so I could go back very, very briefly, but we really kind of covered that part around integrated care and the power of training and education, and then expanding rural naloxone programs. We dropped the language in for your Good Samaritan law for Florida. And these are just some examples. So Project Lazarus as I said, is in North Carolina in the mountains. And they have technical assistance for communities, clinics on overdose prevention, opioid safety education. And they really focus on coalition building, just like many of you do, creating toolkits, trainings for pharmacists, care managers, primary care providers, emergency department staff, law enforcement, and first responders. And then I'm getting a comment that selling naloxone in pharmacies has been a huge help with the stigma. Absolutely. I also want to point out tribal communities. So we've got the Wabanaki Pathway to Hope and Healing. A lot of these things listed on here were funded by the Rural Opioid Overdose Reversal Program, which has been really helpful in getting some of these naloxone expansion programs pushed out statewide. And so a lot of the times these create partnerships between law enforcement and healthcare providers, and really make sure, as someone was saying earlier, they are culturally responsive, and they engage all community members, and they make sure they're prioritizing communities of color in areas where that is of a concern for high overdose increases. So we've got some other examples there. I won't go into everything because you already have some things going on in Florida. And so this is one example I was given. If anyone has anything they would like me to share, you can drop that into the chat. But this is iSave Florida. So there's the website, www.isavefl.com. Get naloxone, stop an overdose. So as far as further stigma reduction strategies, now this is a great booklet. This is the Rural Community Action Guide. I've got, again, the link to that in the chat. And it suggests 4 actions that you can see listed there generically, 4 actions to help address substance use disorder related stigma in rural communities. Many of you have mentioned all of these, right? We have to understand the science. We have to understand the portfolio of substance use disorder research to mitigate stigma and support evidence-based treatment. We have to educate the community with the science of substance use disorder, brains, the adolescent brain, and just disseminate these resources, the educational materials. We have to make sure we're doing tailored, culturally responsive marketing plans to reduce stigma, understand the stigma concerns, the best way to reach a community, create a campaign to address stigma. And then as you've all shared, and I'm seeing lots of claps, we're all very happy, have peers share their stories, disseminate positive recovery stories to support the recovery community. So this is the Rural Community Action Guide. I encourage you, if you're interested, to have a look at that. But again, we know we've got decades of science out there that really improves our response to addiction, empowers our communities to help prevent, treat, and support those in recovery. So we can use the science to debunk the stigma, to support local policies and practices, promote a science-informed response to addiction. So again, there's a lot of tools out there. Again, educating the community that you've all talked about. We know addiction doesn't discriminate. We know it can impact anyone. So everyone in their family or their friend circle has someone that's struggled with substances, struggled with alcohol. So it's a great kind of unifier when we get past that stigma. So we use statistics, we use the latest science to teach the community about addiction, to work with stakeholders in the community, disseminate this knowledge and resources like those overdose reversal kits we talk about the brain science of addiction, especially to adolescents, help them understand you've got the acceleration, you don't have the brake yet. This is why we're trying to work with you. And then other educational materials. So there's a lot of great resources out there. We talked about this marketing plan. The best way, as you know, if you've got a stereotype in your head, the best way is to replace it with a counter stereotype. So anti-stigma marketing can just correct misinformation, contradict those negative attitudes and beliefs. So the community strategy always has to be tailored to the audience. So again, social media, online platforms are going to be more useful. More appropriate communication streams for young people, while maybe a talk at the Rotary Club, not to stereotype, or having public information or an ad campaign, printed materials might be more appropriate for other populations, adult, older populations. And then again, most powerful, sharing positive stories of recovery. When people in recovery share their stories, stigma is just diminished. Community leaders need to facilitate these conversations, support efforts to build the capacity of the recovery community to participate in public discussions everywhere, in schools, in faith-based organizations around addiction treatment and recovery, to reinforce, as many people have said in the chat, recovery works and it is for everyone. So if you don't know, I know many of you have been posting about this, if you don't know much about engaging peers, we want to reinforce this is an evidence-based intervention. We're not just saying this is a nice idea. There's a number of different research and reports around this. And what we know is that stigma elimination happens when the prejudice we feel towards something or someone is changed. And that happens when we build relationships and when we increase our compassion. So when we see the faces of recovery, when we meet the people behind the data, it just challenges that stereotype, challenges that stigma. So yes, I'm seeing in the chat. That's great. I appreciate it. And these things that I'm seeing on here, I encourage you to, if there's any way that we can support you, we have a lot of great intensive training with our partners, Faces and Voices of Recovery, C4, who can teach people with lived experience how to more impactfully tell their stories, about that use of language we talked about, non-stigmatizing language. But what we know from the data is that having someone with lived experience provide education has twice the impact on attitude change and intended behaviors. So yeah, education alone is great, but when you see someone standing up saying, I'm a person in long-term recovery, let me tell you my story, let me connect it to the science, and let me give you the outcomes, it is very hard for someone to retain that stereotype, especially when that happens over time. So we know that there's interventions when education, just factual information is presented, but then we see when people with lived experience support and personalize this information, relate their own life experiences. From meta-analyses of a variety of studies, we see that change. We see it's twice as powerful as just education alone. So really paying attention to ways in which you can engage peers. We have some great resources for you all in Florida that are up there. And again, they'll be linked to when you see the slides. So we've got, that recovery-oriented system of care framework across Florida that you see. And if anyone has anything they want to add in the chat around this, I am not in Florida, so I cannot speak to a lot of this. But we want to make sure you know the resources. If there's anything people would like to share, we can also repost that if there's links. But really recognizing the power of Florida recovery community organizations. And we've got the links there. When you get the chat, you'll be able to click to those, and just seeing that you have a lot of resources. All in for Florida, a recovery project. This was a 3-year initiative with the goal of building recovery groups across Florida into sustainable recovery community organizations. So you are building peer recovery specialists in Florida. You're enhancing support services using those principles of recovery-oriented systems of care. One more resource, or a couple more resources: Hope Florida, a pathway to prosperity. So really uniting communities through these care navigators to guide Floridians on an individualized path to prosperity, economic self-sufficiency, and hope. And then that behavioral health service information and location link is up there, hopeforhealingfl.com. And that navigates the ways that many Floridians can access help for mental health and substance use disorder. So really, connecting in with resources you have. I'm also seeing community partnership for children is mentioned as well. So again, if anyone posts a link, and I'm sure Rebecca can repost that so everyone can see it. So really where we are now is talking through, how can we leverage telehealth and community partnerships? I know I've had you for some time. We're on the home stretch, everyone. Stay with me. So when we're talking about leveraging virtual opportunities, we know that integrated care model that I mentioned, that gold standard, it can be challenging in rural areas. There's already less healthcare resources, and now you're asking for this integrated one-stop shop. We also know there's a possibility that we can use telehealth to expand that access to care. We know that virtual platforms offer opportunities to better coordinate care and establish partnerships across rural communities. So really thinking through what is needed to expand telehealth in rural communities. You already mentioned there's a lack of bandwidth. We need to expand bandwidth. Yes, yes, yes. How can we do that creatively? How can we create partnerships with some of the telecom companies to do that? How can we ask for resources to support that? The same with making sure people have got access to the technologies needed. So where people start, just with any other program, we need to start with kind of some community assessment, some asset mapping. I'm sure all of you have got some version of this in your communities, but not all communities have, and not all communities think through creatively what's available. So if you don't have a local resource guide, really making sure you've got a local resource guide with updated links, contact information. Being online, this makes it a lot easier, and having a point of contact for each coordinating partner. So as you're thinking through how to coordinate services, it's not enough to send someone out with a list, but if you can, make a call and just connect that person to that list, just knowing who that person is you should be calling saves you so much time and energy. And then so once you've looked at what you have internally, you've got to figure out, well, what resources are needed to support that community. And so, really thinking, how can we collaborate across regions? And a lot of this has got to be done virtually now. We've got to coordinate care virtually. We have opportunities, as we've said, to identify creative funding opportunities. So what does that look like? How can we expand rural bandwidth? How can we think through a hub where we can have telehealth equipment that's needed to connect with other counties to avoid some of those transportation challenges? And then making sure, as we talked about, that we're collaborating across communities with not just community leaders or elders, but also diverse stakeholders, diverse communities. So making sure it's not just around healthcare, but we're also looking at criminal justice. We're looking at housing providers, all those recovery supports that we need. We're looking at faith-based leaders. We're looking at the business community, and someone popped in the chat, we're also looking at libraries, right? Because libraries might be able to assist with computers. They've got to create a link for individuals who don't have hardware bandwidth or a technology challenge. They can be a great support. Also, educating. And if we haven't said this, if you didn't get this enough, I'll always slip it in. Connect with peers, people with lived experience. So just really thinking through, how do we center people with lived experience in some of these collaborations to increase that exposure? So some core questions as we're doing this work is really, asking these questions. And you might have many other questions that you're thinking through, but these are just some of the questions that we like to ask, is really, how do we do this virtually? How do we disseminate some of this information and avoid that Zoom burnout because we're all so tired. So what are some creative ways we can use that flipped classroom approach where we share information, then we use our live time to really fully engage people in that planning and implementation process? How do we incentivize people to fully participate? When we're looking at treatment programs, we know when it comes to stimulants, there are no approved medications. That's one of the challenges we have to treat stimulant dependence. So treatment becomes a process that requires long-term attentiveness. So we know contingency management, for example, it gives people tangible rewards for positive behaviors, aids their efforts to stop using stimulants. And we've got cognitive behavioral therapy in our toolkit, again, to help us identify and modify some of that thinking, and that can help people overcome addiction. Motivational interviewing. So all these tools that we use when we address stimulant use disorder, we can also use when we're thinking about how do we partner virtually? How do we create incentives to get people to participate with us? And then, you know, anything where you have motivational interviewing skills, you can engage that to help incentivize people, engage key stakeholders in the planning and implementation process. And how do we ensure live meeting time, as I said, is meaningful, context specific, and what tools will help us meaningfully engage with patients and communities? Some of you are adding things in the chat as well, like thinking about how do you engage older persons who may not be technologically literate? How do you set up community-based technology centers for people that don't have or don't know how to use? And then libraries, as we talked about as well, being that important part, they can help teach people how to use technology. And then again, we've got to do a lot of re-education around stimulants because people don't quite understand all the science behind the stimulants. And we know while stimulant withdrawal is not the same as opioid withdrawal, it's not typically medically dangerous, like we see with alcohol or heroin, for example, but there's a resulting depression, right? There's a resulting depression, especially in amphetamine withdrawal, which can be very severe. So as people are coming into treatment, we've got to look for other issues, suicidal signs, you know, suicidal ideation, and just recovering users we know that have got mental health challenges are really especially at risk. So really helping educate the community around, it's not just one size fits all when it comes to substances either. There may be an underlying trauma, but there are different impacts of those substances on our bodies. So whatever we do, we want to make sure that we are practicing cultural humility. And this is really where I'm going to end with you all a little bit today. And of course, if we have any questions, we can come to those. But just really reinforcing whenever we go into a community, a lot of you, similar to me, are in urban areas and you go and work in rural communities. So really think through, who do you need to engage? How can you listen to diverse voices? Because if you have a diverse community and all the faces around the table are white, we need to reassess our approach. We need to recruit diverse consultants to reflect these communities, diverse planners, and always, 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 you'll see this, we need to center voices of people with lived experience who can speak to what it feels like to be in long-term recovery, what it feels like to go through these systems, and really help us remember what this is all about. And as we're, you know, implementing this stuff, just reinforce, we want a strength-based approach. Many communities have amazing assets. Let's build on these existing assets, build on these existing efforts. Let's understand the history of what worked and what didn't and why, and just really reinforce collaborative opportunities across prevention, treatment, recovery, and I should have harm reduction in there as well. And then, as someone mentioned earlier, and I really appreciate a lot of you being very culturally responsive and saying person-centered, person-first language, non-stigmatizing language. And again, we've always got to center the voices of those with lived experience. If I leave you with nothing, it's just the power of peers is just, we cannot overestimate the power of peers when used effectively and given resources to work effectively. So we're not talking about people just volunteering time. There's some references, very, very fun. And we want to encourage you, if any of this is of interest to you, if you're interested in a variety of work, there are many people just like me out there at the Opioid Response Network, nationally, locally, who would love to be of support. One thing that you, I'm sure, are aware of is that the SAMHSA has thrown a lot of money at opioid and stimulant use. We're very grateful for that. And all our services are free to any of you to individuals to communities to organizations, for technical assistance, for training, for capacity building. So even if you're just trying to think through a strategy, there are people we have, people like myself that do a lot of strategic planning with regions, across multiple states, to really think through how to build some of these networks and how to build some of these things that we need, the infrastructure to address whatever's coming next, because we know it was opioids, we know it's now stimulants, we know there'll be something as things shift. So again, together we believe we can make a difference. Collaboration is so powerful. We are the opioidresponsenetwork.org. I hope you will reach out to us. And I think, Rebecca, we have a few minutes for questions, if there is any questions that came up, or if you have any questions.
Yes, we have just a few minutes for questions, so if you would like to put them in the chat, and Deena can try and answer them, and if not, we will go ahead and close out.
Yeah, I'm just scrolling through to see, because I know there are a few things that came in, so if there was anything you didn't get to ask, I'm sure Rebecca can connect me. So I'm seeing a question on, can you speak on social economics regarding certain urban communities being marketed substances as a green light over other domestic communities? What are your thoughts on that, and what can be done to prevent that? I'm not quite understanding that question, so if that person could get a little bit more clarity on that, that would be helpful. And I really appreciate everyone saying thank you, because it's always nice to be appreciated, Rebecca. We always like that. And if there's any ways we can support you, as I said, please reach out to me or to the Opioid Response Network. We'd love to support you in the amazing work that you are all doing. Thank you all so much. And I'll turn it over to you, Rebecca.
Excellent, thank you. Well, as Deena said, this is all the time that we have for today. And let me go ahead. And we have included Deena's contact information so that you may contact her with any further questions. Deena, we really appreciate and thank all the work you put into this webinar and all the valuable information you have shared with us today. We very much appreciate it. Please see the chat panel for a link to today's survey. Additionally, when I conclude today's webinar, your browser will take you to an evaluation on FATA's website. If you want to receive CE credits or a statement of credit for this event, please complete the evaluation. You will be prompted to sign in or register at the sign-in screen to complete the evaluation. You can register as a visitor at no cost. For CEs to be reported to CE Broker for Florida licensed healthcare practitioners, you must provide an accurate Florida Department of Health license prefix and number the first time you register. After you register or sign in, you will be directed onward to the evaluation. You will need to use the same email address you used today when you registered for the webinar through our WebEx link when you set up your profile in FATA's system. This will help connect your attendance to your profile. You will get a second option later today to complete the evaluation through a follow-up email. The sender will be messenger@webex.com. Evaluations will close at midnight on Wednesday, October 27th. We do not email statements of credit. Instead, after we verify attendance and completion of the evaluation, a statement of credit will be generated as a journal entry within your profile 30 days after the evaluation closes. Again, thank you for participating in today's webinar. We appreciate your interest in our programs, and we would also like to recognize and especially thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's education. Have a great rest of your day. Thank you, everyone.